Hi, my name is Sarah and I'm part of the Parent Suportal team, and today we're talking to Yulli from Myofunctional Therapy UK, and we're really excited to hear about the work she does. So take it away, Yulli.
Hi, everybody. So my name is Yulli Tamayo-Myerson. I'm the founder and director of Myofunctional Therapy UK. I am also the founding president of the British Society of Myofunctional Therapy. My background is dental hygiene and therapy. I've also trained as myofunctional therapist, TMJ therapist, and Buteyko breathing practitioner. Before I did all of that, I was a clinical massage therapist. No, it doesn't want to move.
Yeah, I think it might be.
Oh, there you go. That's fine.
Can you see Kath Jones waiting to be admitted? Can you click on her? I tried and it didn't. That's it. Great.
Yeah, there you go.
Right, listen. Thank you.
So, hello and welcome. We're going to continue with the presentation. So, if you need any further information after the presentation, you can contact me at info@Myofunctional Therapy UK or president@bsmft.org.uk. My professional trajectory, so as I said before, we started with clinical massage therapy many years ago. I was a dental nurse for 12 years, and then I trained as a dental hygienist and therapist, trained on CBT, NLP, myofunctional therapy, Buteyko breathing re-education. TOTS assessment is basically tether all tissues assessments, which includes tongue ties, lip ties, buccal ties. So any tethering of the oral cavity that might be affecting movement and function. I also trained in head and neck acupuncture and acupressure and TMJ therapy. And more recently, I've gone into dental sleep medicine. So what brought me to myofunctional therapy was my little boy. As you can see from that picture, he has his mouth open. He was dribbling a lot, and he had a lot of issues with sleep and behavior. Stomach issues, colics. Up until the age of 4, he was still turning and twisting with pain, stomach aches. He had constant sinusitis and colds, and he always had his mouth open. So he developed dark circles around his eyes, and his behavior, he wasn't hyperactive, but he was withdrawn and he wouldn't concentrate. He had all the telltale signs of ADHD. He was very borderline, so he didn't tick all the boxes. He wasn't diagnosed with ADHD and ADD until the age of 15. And that's when everything started getting very serious for us, because he was desperate to get into university and he was being labeled as having ADHD and ADD, and he wouldn't be able to get to university. He was set to fail all of his GCSEs. So I started digging more into what was going on with his condition. No one was giving me straight answers. We went to as educational psychologists, GPs, ENTs, all sorts of clinicians, dental clinicians. We were worried about his dental appearance as well, because coming from a dental background, he was pretty much a class 3, which is the lower jaw coming forward. And everybody was telling me he will grow out of it. He had large tonsils and he couldn't breathe properly through his nose. So it was, the tonsils are fine, he will grow out of it. So when the college or the school told us that he wouldn't pass his GCSEs, we got very worried, and investigating about it, we found about sleep disorder breathing. And that was a complete revelation to me, because all the signs and symptoms of a sleep disorder breathing are very similar to ADD and ADHD. So I started paying more attention to it, and I decided to take courses abroad, because there was no training here for myofunctional therapy. So during one of the first courses I took, there was a video clip, which you can find in YouTube. It's called Finding Connor. And it's about this little boy who the parents, the mom wants to help, and he just can't find himself. He can't concentrate. And it sounded so similar to my boy that I walked out of the room in tears. And I decided to take all the further courses on myofunctional therapy. So that involved traveling a lot, being away from family. But when I got back from all of that, I started treating him. Within his mock exams for his GCSEs were approaching. So we had 5 months to work hard on his breathing, his behavior, his sleep hygiene. And he passed his mock exams and he passed his GCSE. So he came out with 9 GCSEs. He's now 18 and he's about to enter university. So he's done extremely well. We're very proud of him. So why is mouth breathing really important to keep an eye on? It doesn't just affect sleep. It also affects the teeth, how the teeth grow. It can cause cavities, gingivitis, digestive disturbances. It can cause inflammation of the upper airways. So your throat, the back of your sinuses, the tonsils. It can also create what is called the long face syndrome, which is just the structures of the orofacial complex become elongated. So not only the mandible, which is a hinge mechanism, hangs low, but also gravity pulls. And then all of that gets just deformed, really. It changes shape. So what happens, you can see those 2 pictures on the left-hand side of the screen. When the mouth is closed and the tongue is up, the tongue guides the form of the jaws. And then the lower jaw follows the upper jaw. When the tongue is slow, the tongue is the size of your fist, is very large. It creates extra weight on the lower jaw and gravity pulls. And then you have all those structures, not just malfunctioning, but also changing shape. With the nasal cavity, you have a vacuum. So you have a nasal passage which receives currents of air. That creates a vacuum itself. So if the tongue is not supporting the upper arch or the palate, creating a contraforce, then the upper arch becomes very narrow and high, and that creates a smaller space on the nasal cavity. And sitting on top of the upper arch, it's also the septum. So you have the upper arch, the palate, the floor of the nose, and then you have the bridge of the nose or the nose itself, the cartilage that sits on top. If you have that vacuum creating a high and narrow palate, also that will become disturbed. So you'll create also you develop what is called a deviated septum, which you can see in the bottom picture there. So all of this happens when you are going through development, and it's important to keep an eye on an open mouth posture. So it's not just going to affect dentition, it's not just going to affect cavities, but it will also affect how your child sleeps and behaves the following day. So what is myofunctional therapy? Is neuromuscular re-education of or repatterning of the orofacial musculature. So we work with exercises and we work with behavior to tonify and normalize function. So one of the things that we look at is the bilateral functioning of the complex. We have a jaw that has is a hinge mechanism and attaches in both sides. It's one of the most complex jaws in the body. If it doesn't work properly, it can go offside slightly, creating problems with the ears, creating problems with the C-spine, and also creating problems with the airway. So if you have a jaw that is sitting low and during development hasn't had the support of the tongue or hasn't been close to the upper jaw, i.e. it has been the person has been a mouth breather, the jaw sits low, but it sits behind also. And that position can cause problems with the airway. So when we're looking into myofunctional therapy, we're not looking just at correcting the posture of the jaw, but you're looking at correcting breathing patterns, chewing patterns, swallowing patterns. The exercises are pretty much composed of isotonic or movement, range of movement exercises, or isometric, which is just a static training, i.e. hold your tongue to the roof of the mouth and keep it there as long as you can. And then we also look at the oropharyngeal structure, whether the tongue is collapsing to the back of the airway, whether the airway is collapsing within when you fall asleep. So we check at children who snore, children who maybe are heavy breathers at night and twist and turn a lot. Bedwetting is another thing that we look at. It has a correlation with the sleep disorder breathing as well. So the three big goals of myofunctional therapy are nasal breathing, not just during the day, but also at night. The whole tongue to be at the top of the palate, not just the tip of the tongue behind the upper centrals, but also the mid part and the back of the tongue. So ideally you have a full suction of the tongue up all the time, not just during the day, but also at night. And during the development of the upper arch, it is really important that that tongue sits there, because it will help keep those spaces in between the teeth and create that beautiful arch form. If it's not sitting up there, then the vacuum that I was explaining before happens, and then the teeth get distorted and breathing gets affected. So, and the other thing we look at also is posture in general, head and neck posture and body posture. So signs that we look at when we see a new patient. Oh, sorry. So we look at enlarged tonsils. So that's the first picture, whether they have enlarged tonsils, are they kissing tonsils, can they breathe through their nose? We look at whether the nostrils are the same size, whether there is one more narrow than the other one, indicating maybe a little kink on the septum or maybe a deviated septum. We also look at the nose in general, whether there is a twist on the nose that can indicate something that needs to be addressed by an ENT. We also look underneath the tongue to see whether there is a restriction of the tongue that has avoided or impaired that tongue from reaching the roof of the mouth during development. So you can see that picture with the girl that cannot reach that roof of the mouth, and the teeth have not been supported in that arch form. So she has developed a high and narrow palate. You can't see it in that picture, but she also has a twisted nose, a deviated septum, and she has breathing problems. She's a mouth breather now. So all of that goes hand in hand. And the top picture with the eyes is the dark circle around the eyes, very indicative of a child that doesn't sleep very well. And that sunken eye look that tells you that the child hasn't rested well. Then we also look at the tongue, whether there are cracks in the tongue. This is called a geographic tongue, but we also look at that because there are sometimes deficiencies in nutrition that we need to approach as well from a different angle. And we also look at the borders of the tongue to see if there is what we call scalloping. We look at the lips to make sure that there is, if there are signs of mouth breathing. So that again is a high and narrow palate, and you can see instead of an arch form, it has a more triangular form. The palate looks, this child is not a thumb sucker, but it looks like it's been having an imprint of a thumb. The palate just hasn't been supported by the tongue at all. Then this child has a very narrow airway. We're supposed to be able to see two dark caves right at the back of the mouth. And this will classify as a class 3 Mallampati, what we call a Mallampati score. And it just checks the back of the airway, how much of the back, the oropharyngeal wall you can see. And then we have a tongue tie. If you were to ask that girl with a tongue tie there to stick her tongue out, she will be able to stick it out completely, but the tongue will go down. It will not go straight. So she looks like she's got it straight there, but it's not out of the oral cavity very much, and the tip of the tongue is bent. So if you ask her to extend the tongue further, it will go out but down. So often it gets misdiagnosed as not being a tongue tie because the tongue can go out, but it's how you can function the tongue in lateral movement or up as well. And then you have a lip tie, also commonly ignored, which also creates problems with speech, creates problems with the seal, the lip seal, and suck, swallow, breathe reflexes that you need on a newborn. And then you have the scalloping of the tongue, which indicates that the upper arch is very small and the tongue is constantly pushing onto the teeth. So people who have a scalloping of the tongue will be grinders and clenchers. They can't seat the jaw properly. And then you have an elongated palate. In this case, the soft palate is very long and you can't see at all the back part of the oropharynx. We look also for open lip posture, so the inverted smile look. So this child also is a mouth breather, very clearly, very cracked lips, and has problems sleeping, also with the sleep disordered breathing and snoring. And then you have the wear of the teeth, where people have been just grinding their teeth off, trying constantly to get more air into their bodies. Oh. We also look at posture, forward head posture, which indicates that the person can't breathe properly and possibly the tongue is also anchored to the floor of the mouth and they can't move the tongue properly. So we swallow about 3,000 times a day. If the tongue is held down to the floor of the mouth, it will create a force forward, which then in turn will create problems with posture because the head is very heavy. It should be sitting on top of your shoulders to keep you upright. If it's forward, then you create a compensation on the lower back to keep you upright. So we look at that as well. We look at the development of the face, whether they are long face, and we also look at the lower jaw in reference to the upper jaw, whether they have that what we call retronatic mandible or receded mandible. So myofunctional therapy is really about connecting the dots and finding solutions and a team of specialists that can work together. There is no way we can do all of this on our own. We all the myofunctional therapists will try to connect the people that will help the child or the patient they're treating. So we'll be looking at nasal breathing, adequate lip seal, tongue to the palate, rest posture, strength of the tongue, of the oropharynx, the lip musculature, whether they have any habits like thumb sucking, like hand sucking, or even tongue sucking. Sometimes people would put their tongue in between the lips and then suck, and that creates functional issues as well. We look at bilateral chewing, correct chewing, and drinking. So with the chewing mechanisms, the lymphatic system doesn't have a pump mechanism like the circulatory system has, which is the heart. It's aided by the chewing mechanisms and by the diaphragmatic breathing. So the diaphragm is a form of pump for the lymphatic system. So if you're breathing through your mouth, you're breathing upper chest, you're not using your diaphragm. So that pump mechanism is impaired. If you're not chewing properly, i.e. you chew a couple of times and swallow, not only you're giving your digestive system a lot of work to do because the food is not properly swallowed, but also you're probably swallowing a lot of air as well. And you're not pumping that lymphatic system up here enough to keep it regulated. Then we look at behavior, which is affected by sleep and poor breathing. And we look at sleep in general and general health. So poor memory recall is also affected by sleep and by breathing. I think we're running out of time. Is that right?
Yeah, unfortunately.
Sorry.
Okay.
So that's pretty much what we do with myofunctional therapy. We use different tools and different techniques to work with the children. And sorry, I'm going to show you a couple of videos, but I think we'll try. So with special needs, we work with children who have had issues with sleeping. You can see this little boy here hasn't had, I have permission to show these videos. Mom is really keen on spreading the message. So this little boy is autistic. When he came to me, he was nonverbal. And within a month, 2 months of therapy, he started closing his lips and he was engaging with me. He was able to then do, after 2 months of therapy, to do the exercises I was asking him. He was sleeping then with his mouth closed. He went from waking up 5 times during the night to sleeping through the night. So the mom called me one day and asked me, what's going on with my son? He's not waking up, and I'm waking up 5 times to check him. But he was just sleeping better, and you can see there are no more dark circles under the eyes. And he started making sentences. So we're activating all those systems, all those neuromuscular connections. He started making sentences of 7 words, and they're very happy. So there's a little video here of him doing the exercise. I don't ask them to put their hands up, but he just wanted to do it. And he became very good at doing this exercise. So he's very tall now. He's taller than me, but he's still my patient. He's a lovely chap. So this one is also, this little chap is also autistic, mouth breather, very high and narrow palate. As you can see there, the tongue doesn't reach up. The airway is very narrow and constricted, snoring, not sleeping properly. And then with myofunctional therapy, we managed to open up the airway. This is a child that hasn't been operated on. It's just purely engaging those orofacial complex. And then little Queen also agreed to show all the pictures. You can find her on the website Just for Children, and you can see her story. She's a lovely little girl. When she came to me, she also had open mouth posture and a lot of dribbling, and she was having oxygen supplementation. And within a couple of weeks, we got her mouth to close and sleep with her mouth closed as well. And she's doing amazingly well. So she's been my biggest teacher, that little girl. I love her to bits.
Well, we see Quinn as well, and we love her to bits.
Yeah, she's been, I've learned so much from her. She's amazing. Yeah. Parents' readings, I think these books have helped me a lot, and they are in my clinic, and I recommend them to not just clinicians, but to parents. The Sleep Wrecked Kids is a really good book, easy to read, not too much jargon, so you will understand what they're saying. Close Your Mouth by Patrick McKeown. He was my teacher, my educator on breathing re-education. We have a study club actually next month where he is coming on to talk, so I can give you all details of that. It's completely free of charge. It's just there to educate people, so I pass on the details for next month, so you can join Patrick and the society. Tongue tie book is really, really good for parents to understand what a tongue tie is and why it affects the oral complex. And the latest book of James Nestor, Breathe, is a really good book as well. So all of them are amazing. They're there for a reason. Very good books for parents to read. I'm not the only myofunctional therapist. So as much as I like to see everybody and help everybody, you can also find more myofunctional therapists. There are not many of us in the UK. But the British Society of Myofunctional Therapy was established to help people connect with the therapists. There are only about 7 of us currently. We will be looking at running courses for more clinicians to learn about myofunctional therapy. So I hope this was useful, not too long. And I'll hand you over to you again. I'm sorry if I took
no, no,
long, but hopefully it was.
No, that was brilliant. Thank you so much, Yulli. Let me just do options.
There you go. I've just stopped sharing. Yeah.
Thank you. That's great. Thank you so much. So I will chop down the part where we're having technical difficulties and post up so parents can have a look. And if you could send us the link you were talking about for the thing next month, so that we can post that information up at the same time, so people know where to go. But thank you so much.
You're welcome. Yeah. And we'll see you soon, hopefully.
Yeah, brilliant. Thank you.
Take care. Bye.
Bye-bye.